Hi, I'm Colleen Hutchinson. I'm here with Brad Davis, and we are at the Wynn Encore Las Vegas for the 19th Annual Minimally Invasive Surgery Symposium. Brad, thanks for being with us.
My pleasure.
Can you just tell us a little bit about yourself?
Sure. So my name is Brad Davis. I'm the Chief of Colorectal Surgery at the Carolinas Medical Center with Atrium Health in Charlotte, North Carolina.
So with this new position you've took on as the Miss Colon Program Co-Director, what were your goals for the program?
You know, the biggest goal for the program was to provide a meeting where there's a lot of practical advice for surgeons. I think we all have meetings we go to where there's a lot of esoteric, literature-based, but we really wanted to focus in on the practicing surgeon working on the front lines and identify areas where we can assist them in making decisions about patient care and more being very practical. I think that was the main focus of the program this year, and most of the topics we talked about we're really focused on that, which I think is different than in years past.
Mm-hmm. Yeah, can you talk a little bit about the evolution of this program over the last 10 years?
Yeah, so I think 10 years is about how long I've been coming, and I think, when we first started doing this, it was about, teaching surgeons specific techniques around minimally invasive surgery. Mm-hmm. And what's happened over the last 10 years is that surgeons are doing this. They no longer really need a how-to and a show and tell. It's more about understanding a discipline and how to manage certain complex patients and their disease processes. So I think it's evolved to how do I do an operation to how do I take care of patients. And then I think it's really reflecting on the fact that minimally invasive techniques are much more prevalent. Surgeons are doing much more advanced minimally invasive techniques. Their skill sets are really significantly improved. So I think that'd be the biggest change I've seen in the meeting over the last 10 years. And again, I think from the colon agenda perspective, I really feel like we've gone away from, kind of the esoteric and the management of very specific things that most general surgeons aren't going to manage. Mm-hmm. To I'm a surgeon practicing, what are the common things that I'm going to take care of, and what's the best way to do that?
Okay, so that kind of leads into my next question about, really I wanted to touch on the value of the colorectal surgeon attending this program.
Yeah, I mean, I think for the same reasons. I think, for the colorectal surgeon that's, again, trying to take care of complicated patients, it's an opportunity to interact with other colorectal surgeons who are expert faculty members. Sure. I say this every year, and it's true again this year. I learned so much coming to this meeting. I watch, Dr. Cannon talk about how she does robotic sigmoid colon surgery, and just a little nuances, little tweaks to the way she does the operation. I can tell you I'm going to go back and incorporate those into my practice. So I've been doing this a long time, and yet I'm still every year as a practicing colorectal surgeon learning new things. Dr. Paquette, one of our faculty members, just commented in our session this morning saying, prehabilitation makes a lot of sense. I think I'm going to go back to my program and my practice and really look at how we can implement it. Mm-hmm. So it's so relevant to both general and colorectal surgeons. And if I can learn something every year from doing, from attending this meeting, I know everyone can. Yeah,
that's echoed always by presenters every year who I interview. Yeah. Can you talk a little bit about the role of Eros in colorectal surgery?
Yeah, I think, it's really mature in colorectal surgery. Programs have been well sort of proven concepts in terms of patients are getting out of the hospital faster, they're having better outcomes. So enhanced recovery is really the mainstream of how we take care of patients. And in my institution, for example, it's really a core competency of the whole surgery care division, enhanced recovery around all types of patients and types of procedures, whether it be hernia repair, hepatobiliary, colorectal. And what that does is it decreases your variation so that you have a lot more people that are taking care of your patients and know, okay, these are the expected steps, and the nurses and the respiratory therapists and the surgeons and the residents and everybody basically is on the same page. So that creates a lot of opportunity for improvement because there's just less variation in how we take care of our patients.
Okay, thank you. I'd like to switch gears and touch a little bit on robotics. Mm-hmm. I just did one of my on-the-spot columns that goes in General Surgery News on robotics. Yeah. I hadn't done it in a couple years. And I tried to get a good mix of different types of surgeons to talk about it. And I would say from the colorectal group, it was interesting. Their take on it is different than, for instance, in hernia. So I'd like to hear your take on the evolution of robotic surgery, specifically in colorectal surgery.
Right, and I can speak to someone who's probably a little bit late to the table for robotics. I think when the robotic platform first was introduced, it didn't make a lot of sense to me in terms of advantages to my patients. I gave a talk years ago about, the future of minimally invasive surgery was going to be laparoscopy, because I just didn't see that robotics was going to be something that was going to be, have any meaningful impact to our patients. Now, having said that, in the last 2 years with the evolution of the newer technologies, I feel that the robotic platforms have really allowed us to do things that we simply couldn't do with a laparoscope, specifically related to pelvic surgery. And I think a lot of us who are doing it now, recognize that there's probably not any significant outcome difference for our patients, but there's just some nuances about the robotic platform that it's just hard to put a financial gain or an outcome gain to. But in terms of just being able to do operations that probably would not be able to be done laparoscopically, and doing them in a way that I think is just simply better. So I think there's some advantages to that. Now, do I think it's the platform for every colon operation? I personally don't. I know that our faculty at the meeting would certainly make a case that the robot is the right tool for every colon operation they do. Again, in my hands, it's it's much more limited. So it's here to stay. I think the platforms have really come a long way. I fully believe that it's improved our ability to do operations in more complicated patients.
How do you decide then when to use the robot?
So I think I base my decision on where the pathology is. So certainly I really have not done a laparoscopic rectal dissection in years. I use the robot for all my pelvic surgery. I use it for most of my left colons, and it's just the wristed instrumentation. It's the optics. It's the ability to work in tight spaces. Those are all the things that I think just make it superior to laparoscopy. But for a straightforward for a straightforward right colon operation, or something more proximal, I just don't see that there's that big of an advantage.
Okay, and what would you say about implementation of the robot in colorectal surgery for all general surgeons across the United States?
Yeah, I mean, I think as newer competitors come to the market, the cost of the robots start to come down. Some of the cost of doing the cases starts to come down. I think you're going to see increasingly, surgeons moving to robotic platforms, and I think that's going to happen for a number of reasons. I think some of it's going to be just simply wear and tear on on ourselves as our patient population becomes more obese. Operating on these patients can be just more physically demanding, and I think there's some advantages as it relates to that with robotic technologies. I think as surgeons are aging, you'll see again a transition away from laparoscopy to robotic surgery. But I think is predicated on the fact that we have to get the cost down. I think when that happens, we'll see an expansion.
Well, you just touched on aging surgeons, which brings up another point about the education of residents and fellows coming up. And what would you say to them right now?
Yeah, I mean, I've seen this really evolve. I mean, I think we're training a generation of surgeons that are going to be uncomfortable doing open surgery. I mean, there's just not that many cases that we're doing anymore open. Just the way we used to have minimally invasive fellowships, I think we're going to start to see some advanced training in open surgery, complex abdominal surgery. But I think, yeah, for someone who's in residency now, I think they definitely want to have access to robotic platforms and really try and get their robotic skills while they're in residency, knowing that they'll probably have to, mature those skills as they get out into practice. But I think increasingly we're looking at, trying to make sure that our trainees have proficiency in robotic skills, whether that be through simulation or for advanced cases. The primary challenge with teaching residents robotics is that it doesn't make a lot of sense to do robotic surgery for some of the basic basic procedures like a lap chole or an inguinal hernia, simply again because of the cost. And so there's going to be some challenge in getting young junior surgeons as well as their residents through that learning curve, because there's not the access to the more straightforward cases. Again, as costs come down, we start using these platforms in more things like inguinal hernia repairs, ventral hernia repairs, cholecystectomy. You're going to see more and more penetration of that in the training programs.
And then to further complicate things, there are new platforms coming on the market.
Right, yeah, and that'll be, I think, good for overall. I mean, as I say, I think more competition will mean reduced costs, and I think that just pushing the envelope in terms of the technologies. I think it's an exciting time. I think we have to be careful that we're monitoring quality outcomes and value for our patients at the same time as trying to push the envelope in terms of technology. Some of the newer technologies make a lot of sense. Some of them are costly without a lot of added benefits. So I think there's going to be a balance.
Well, Brad, thank you for your time and everything we've gone
Okay.
through today.
Thank you.